Good morning. Is that too loud? I want to get started as soon as possible so that we can get as much information as we can. My name is Arlene Brothers, and I'm with the Triple Negative Breast Cancer Foundation. I work with Haley Dinnerman, who just spoke to the group in the big room. A few things at first. Just wanted to let you know that the session is being audio recorded and web streamed. And this will be, and it's on the Living Beyond Breast Cancer YouTube channel. So this will be available after the conference, and if you want to spread the word, if someone missed the conference, they can link to it. Bathrooms are down the hall and to the left. And I think that's all for, and we're trying a new thing. We're going to be doing text questions rather than passing the mic around at the end. We'll have that information up on the screen, but if you could sort of keep your questions in mind as Dr. Cristofanilli goes through the information, and then we'll put up the text number, and you can text that in. Kathy, what do they do if they don't want to text or have a phone or don't write it on a piece of paper? Okay, so we'll be up here, and you can just bring your question up on a piece of paper if you aren't comfortable texting, or if your phone doesn't have that capability. As I said, I'm with the Triple Negative Breast Cancer Foundation and wanted to tell you a little bit about some upcoming things. First of all, we have a webinar and teleconference that's specifically African American women and triple negative breast cancer. That's happening on October 31st. And I'm not sure, what time, do you know the time? It's on our website, and it will continue to be recorded on our website, so if you miss it, you can link to it. And also Triple Negative Breast Cancer Day, this is our third year for 2015. I know many of you have participated in that. It's a grassroots awareness day just for us, so people across the country, and even in other countries, we've had requests to hold events, awareness events, fundraisers. It can be an online event, but it's basically a day that we just come together and spread the word about triple negative breast cancer. And you can go to our website and reach the Triple Negative Breast Cancer Day website and sign up for events beginning now. So anytime you want to find out more information about that. Now I'd like to introduce our savior for the day, Dr. Massimo Cristofanilli, who came in at the last minute. We're so thrilled to have such a leader in triple negative breast cancer. And a little bit about Dr. Cristofanilli. Dr. Cristofanilli is an internationally renowned breast cancer researcher and clinician, and is the director of the Jefferson Breast Care Center at the Kimmel Cancer Center and Thomas Jefferson University and hospitals. With more than 25 years of clinical, basic science, and educational experience, Dr. Cristofanilli also serves as Deputy Director of Translational Research. Prior to joining Jefferson, Dr. Cristofanilli served as Chairman of the Department of Medical Oncology at Fox Chase Cancer Center and head of the center's Inflammatory Breast Cancer Clinic. Before that, he founded and served as Executive Director of the Morgan Welch Inflammatory Breast Cancer Program and Clinic at the University of Texas MD Anderson Cancer Center in Houston. Dr. Cristofanilli is a widely recognized leader in the translational research and treatment of inflammatory breast cancer, the rare and aggressive form of breast cancer in which cancer cells block lymph vessels in the skin of the breast. Moreover, he has recognized expertise in the development of novel diagnostic and prognostic markers in primary and metastatic breast cancer. Dr. Cristofanilli's research aims to improve personalized medicine for breast cancer patients, focusing on molecular targeted agents, biomarkers, and gene therapies, and bridging the gap between the bench and bedside in a more practical and smarter way. A forte of Dr. Cristofanilli is his team-based and multidisciplinary approach to medicine. And we welcome you, Dr. Cristofanilli.
Well, thank you for the nice introduction. It's Nice to be here, even though I'm replacement. I will try to do my best because I feel very passionate about research in triple-negative breast cancer that somewhat overlaps with what we do with inflammatory breast cancer for metastatic breast cancer and will become apparent during my presentation. So Dr. Nanda couldn't make it, as you know, but she was kind enough to provide a slide set, and I just tweaked and modified just to make clear that obviously we have additional information that could be integrated, but she did the backbone. Most of the presentations belongs to her. So why don't we start and try to see what we know, what we're learning, and how you can help. So first, what we know. We're going to go really very simple on the definition of the known risk factors. And we'll update on something on that. And the current treatment options, standard options for triple-negative breast cancer. I think what we're learning will include other opportunities for a clinical trial, for new agents, for the way we can approach breast cancer in general and triple-negative in particular, and how the heterogeneity of this disease really speaks, in fact, that the disease, breast cancer in general, is much more heterogeneous than we used to know. And then, of course, what kind of role you can play in advancing our knowledge. So what do we know? First of all, the definition of triple-negative breast cancer. I think everyone in this room knows that a triple-negative is negative for something. And these are the standard markers that we test our breast cancer specimens, estrogen, progesterone, HER2. This may not be enough to detect triple-negative. And for example, as you know, the definition of ER positivity has changed over the years. So right now, just having more than 1% of cells expressing ER really indicates still an ER-positive disease. But when you go to molecular tests, you find out that many of these low expression ER are in fact what is called basal-like, and we'll talk a little bit more about, so in fact triple-negative. I think if we carefully look at the biology of the disease, breast cancer in general, the percentage of triple-negative is expanding and the percentage of ER-positive is really decreasing. And that's obviously important with implications for a number of treatment that we give after. So the cases of breast cancer is 232,000. If we have 15-20%, but again with a warning that maybe this could be even larger, up to 30% of breast cancers, then we have a large number of cases with triple-negative breast cancer we have to deal with. And unfortunately, we still use chemotherapy as a standard chemotherapy for treatment in the early phase and the advanced phase, because there are no targeted therapy approved. In the past, we used to have some therapies that appear to be effective, particularly in triple-negative, as you know, bevacizumab and ineparib, Parp inhibitor. We'll talk about that for a minute. So a few years ago, this is a publication in 2001, we were informed that breast cancer was not only ER-positive and ER-negative disease, but there were in fact a different subtype, 5 intrinsic subtypes, based on the expression of more than 400 genes. So this is mRNA expression profiling, then put together based on their original expression of ER-PR, and we start to identify groups of specimen and patients. They not only have a different biology, but they have also different outcome based on the fact that they received the same chemotherapy and the same systemic treatment, but didn't have the same benefit. So clearly, this is an intrinsic difference and an intrinsic subtype of disease within the breast cancer. And we start to recognize that the basal-like and the HER2 are the ones have a worse outcome. The HER2 because HER2 is an oncogene that drives the outcome of this patient, and the fact that these patients have many times metastatic disease very early on. And the basal-like, obviously, because there's no obvious target. Now, we know the story for the HER2. We were able to identify this is a driver oncogenes. We developed therapies for these HER2 oncogenes, and the outcome changes. And now the HER2 survival is much different. But the basal-like, that include most of the triple-negative, has not changed. So when we look at the basal-like subtypes, in fact, it depends on the cases series that you look, 10 to 25% of all tumor are basal-like triple-negative. Essentially, 75% of triple-negative fall in the basal-like. There are a few, actually, when you use molecular subtyping, are reclassified and moved to the luminal B. And we don't have time to go into the details of this, and certainly I don't want to confuse you. The cells for which this breast cancer generate are a little bit different. This is more enriched of what we call cancer stem cells. And these are the cells that are mostly resistant to chemotherapy in general. When you look at the genes that are mutated, p53 is mutated in a high percentage of this, and p53 genes is a master regulator of cell cycle, and so is responsible essentially for controlling the way when the cells get out of the cycle. If it's mutated, the cells will continue to proliferate, and certainly is associated with resistance to anthracyclines. That is very much used in breast cancer treatment. And of course, many times is also BRCA1 associated, so many of the patients that have the hereditary breast cancer, a BRCA1 mutation, have in fact a BRCA triple negative disease. So which are the risk factors? Again, is more common in young women, women with African and Hispanic ancestry. So the most aggressive form of breast cancer appears to be a triple negative. BRCA1 mutation, as we said, the majority of BRCA1 mutation are in fact 75 triple negative. For the BRCA2 is different. We have a combination of ER positive and triple negative disease. So you see the percentage actually decrease. And so every patient that is a young woman with triple negative disease should in fact be considered for genetic testing because they may have a risk for additional breast cancer, for ovarian cancer. And of course, when it's time for surgery, this is very important because are you going to perform a bilateral preventive mastectomy, prophylactic mastectomy or not? So hereditary breast cancer is approximately in the overall general population 10%. In the familial is 15-20%. Now, the more we discover about the genes that predispose to breast cancer, the more these two will overlap. So the hereditary condition will increase, and the familial overall, without knowledge of which gene is involved, will decrease. So when you suspect an hereditary cancer syndrome, well, obviously, if there are other members of the family, 2 or more close relatives, early age of diagnosis. We see many times women that have their breast cancer early on, 30s, and then they have a breast cancer age 50, where these women have, again, multiple primary tumors, and they need to be tested because most likely they may have an hereditary cancer syndrome. When the tumor is bilateral, multifocal, of course, if you have rare tumors or cancer, cluster of certain cancer, colon cancer, melanoma, sarcoma, there is a transmission that goes from the mother to the daughter, and of course, specific groups, the ethnic groups that have a genetic mutation that are known to predispose in higher frequencies than the general population. So we know that genetic predisposition is always in the news. I think the Angelina Jolie effect was very obvious just last year. What you do when you have a test that's positive for a predisposition, we know that there's a high chance of developing a triple negative breast cancer, so most likely the best thing to do is start prophylactic mastectomy. But still, for the patient to develop a cancer where they are BRCA1 and 2, we have not incorporated this information in better treatment. There'll be a number of studies looking at the sensitivity of these women to specific agents, the specific drugs, Parp inhibitors, and of course, carboplatin and cisplatin, platinum salts in general, are the agent that seems to be benefit these women more, but there is no direction in FDA approval. And of course, as we say, we increase the knowledge regarding to the hereditary condition. More genes that predispose to breast cancer discovered are this similar in terms of approach and sensitivity to treatment to the BRCA1 and 2. Just recently, 3 weeks ago, the PALB2 gene has been associated with, has been essentially published a study that show 8 or 9 times increased association. So clearly this indicates that when you are predisposed to a certain breast cancer, you have a defect in the DNA repair, and some of this chemotherapy that target DNA repair mechanism or target certain mechanisms that drag the reproduction of these cells are very important and maybe providing a better sensitivity and better benefit to these women. But this is just a fraction. So now if we go back for a moment, forget about the hereditary condition, talk in general about the treatment of breast cancer when we go into specifics. As we say, when someone presented with a newly diagnosed breast cancer, we're going to look at the tumor size, the lymph node status, and the fact that there are distant metastases or not. So this will give us the staging, stage 1 to stage 3, for women newly diagnosed, stage 4 with metastasis presentations. The metastatic presentations in general is not curable. The others, obviously, so in that case, the treatment is palliative. And for the others, there are different approaches for treatment. And of course, based on the standard biomarker that we use right now, hormone receptor positive may get hormone therapy with or without chemotherapy, biological therapy for HER2, and there are many, and we are not talking about that. And of course, for the HER2 ER, there are even more options because these are the triple positive. Triple negative, as we say, mostly chemotherapy. There are a number of advanced diagnostic tests that can be helpful now to better understand how these specimens are, in fact, useful for information for treatment planning. This is not a session for going to the details, but just to say that immunohistochemistry in fish are the standard, but there is a possibility to use RNA expression for molecular subtyping, and I'll show you at the beginning that there is, in fact, the possibility to identify this basal-like as part of the triple-negative breast cancer, and some of these low expression of ER are, in fact, also basal-like, so behave like a triple-negative disease. We can look at protein expression to see the sensitivity of some therapies, HER2 therapy, ER-positive disease also. When you get neoadjuvant therapy and there is a residual disease at the end, we can look at the residual disease to see what is driving the resistance to treatment and maybe plan for other treatment after. And in metastatic disease, obviously, the most important could be this NGS, so genomic sequencing. We'll talk about this later. So, patient when newly diagnosed depends on the size of the tumor. They may be treated with neoadjuvant therapy or adjuvant therapy. So neoadjuvant is done before surgery, and typically in the past was done for patient who had unresectable disease. They required a downstaging, decrease the size of the tumor. And of course, the treatment objective is always to cure and prevent recurrence. Lately has become more and more, as you know, an area where we can develop new drug and see how we can, this is a chemosensitivity or treatment sensitivity test, because we have a way to assess upfront how the response to treatment it is. In the adjuvant, as you know, after surgery, typically this is for stage 1 and 2, you give the treatment for curative effect, and you don't have a way to see, you just need to wait and see. Sometimes the effect of the therapy is different. We have seen at ASCO the presentation with regard to the ALTO study where different HER2-targeted therapy were put together, because in the neoadjuvant phase they work very well differently, and there was an effect on the combination. That was not seen in the adjuvant phases, suggesting that there is a difference between treating micrometastatic disease and treating the bulk of the disease. And of course, in metastatic disease, the treatment is only palliative, but our palliative treatments are improving, so the palliation can actually proceed for many years. So which are the standard treatment for early breast cancer? Of course, typically the treatment are pretty much the same in the neoadjuvant and adjuvant, and the breast study in the past showed that there was no difference in survival, especially when you treat a disease that is operable. And anthracene and taxane-based therapy are usually the backbone, even in triple negative, because I think we cannot stay away, even though there is indication that platinum salts can be important. The order really doesn't matter for the adjuvant setting, but for the neoadjuvant, there have been a few studies, especially coming from the MD Anderson group, that show that if you give taxanes weekly before an anthracycline, you probably have a better pathological response, just because the effect on the tumor and the vascularity of the tumor. Of course, we know the surgery can be mastectomy or lumpectomy. There is no effect on the survival, depends on the feasibility of the treatment. Certainly radiation therapy in case of lumpectomy or even in case of large tumor is something that needs to be considered. It is usually done sometimes in an abbreviated fashion. So this is to summarize, systemic option for patients with primary breast cancer, adjuvant treatment, you do get surgery first, chemotherapy, radiation, and of course in case of women that are ER positive, you will give additional therapies for the triple negative that will conclude. And I think this is the way we want to start to investigate more, because we want better way to monitor patients who have a high risk triple negative. With the neoadjuvant treatment, as we mentioned, patients that are inoperable, large tumors, do chemotherapy up front. Most of these patients will respond to chemotherapy. Some of them will respond completely. The fraction of patients respond completely varies between 20 to 40%, meaning the tumor is completely gone at the time when pathologists look at the specimen, and then surgery, radiation. You see that in both cases, particularly in the neoadjuvant cases, you really need to have a multidisciplinary approach, because you need to have imaging to monitor the response, you need to have the surgeon and the medical oncologist to agree on the time of surgery. Some patients that will not respond should not go directly to having surgery, because there will be an issue with local recurrence. in their radiation therapy. So that's something that we need to consider, particularly for complex cases. So this is an example, locally advanced breast cancer. You have a locally advanced neglected tumor, and you have an inflammatory breast cancer. I couldn't stay away from showing this, I'm sorry. So this is a tumor that will respond, and in fact, it was not even metastatic. It took a long time to get to this point, was neglected. It did grow, but did not metastasize. This one in just a few weeks, and was already metastatic, and really didn't respond ever to anything. So in spite of the fact that they're same size, you can say, but they respond different, they have a different biology. I think we need to really identify this difference in order to improve the survival of these women. So this is a Kaplan-Meier curve looking at patients that were treated with the same chemotherapy at MD Anderson, look at the pathological response that they obtain when the pathology look at it, and showing essentially that the triple-negative patients may do well if they have pathological CR, but if they don't, they do worse. And you can imagine that one of the reasons is because we don't have endocrine therapy, we don't have HER2-targeted therapy, and whatever is left is really very aggressive. So the goal is to not only monitor these women, but try to find what can we do for the ones that do not get to the pathological complete response. And as you know, there is an effort now at the NCI trying to understand the good responders, that we can learn from the good responders as well as we learn from the lack of response. So in both ways, I think we can learn something that we can be useful for triple-negative breast cancer group. The group of patients that do not respond, eventually we have a recurrence. Which are the recurrence pattern of triple-negative breast cancer? Well, as you know, the first 2 or 3 years for an aggressive tumor are very important because that's where most of the recurrence happen. And usually it's unfortunately a recurrence that happens to be in the viscera. So lungs, liver, and the brain, it cannot be exactly the first time, but it's one of the other sites that has a 20% chance to recur, in some cases even 30%. Less common in the bone. I think when you have a disease that is confined to the bone for a long time, you want to wonder, always do a biopsy of the metastatic site, always trying to confirm that this is a triple-negative breast cancer, because we know the cases that are ER positive up front and become triple-negative, they lose the expression of ER, but you'll be surprised to see that because the disease is very heterogeneous, some cases may be, in fact, ER positive in the recurrence, particularly in the bone. So we had a number of cases that were actually like that. And of course, it's opened up to opportunity to treat with endocrine therapies. So, well, if this is a disease where we have only chemotherapy, you can look at the NCCN guideline. It essentially is a list of chemotherapy that are used in the metastatic setting. Absolutely, that's not enough. We know that this is just a list of available treatment, but we have to do much better. So you can re-challenge with taxanes if you're using the neoadjuvant setting, depends on the time. And of course, right now there are many taxanes, and one of the combinations, ixabepilone and capecitabine, is at the bottom of the list. The question is, how to select, how to use sequencing. Usually oncologists, they feel pretty good about, I know what you should do right now. But in reality, we have no way to select. How do you know that you need to be treated with a combination instead of single agent? Typically, it's the symptoms, it's the amount of disease, and how we judge this as aggressive or not as a recurrence. So it really is very subjective, and there is no objective way till now. I think there are a few other things that we can talk about. Of course, clinical trials, every time it's possible, we need to identify which clinical trial may be useful for triple-negative populations. Now, of course, there are differences in being just participating in a clinical trial or try to participate in clinical trial developed for triple-negative patients, and we'll talk about the different phases and whatnot. So far, I think in general terms, there are no standard treatments that are targeted for triple-negative, and of course, the search is on. And so now the question is, what are we learning? I think the first thing that we are learning is that we have been putting more effort and more research in triple-negative breast cancer. It's not only ER negative and HER2 negative disease, but it's also genetically unstable disease. So if you get to evaluate the chromosomal abnormality, the DNA breaks in a patient that has triple-negative disease, there is much more than any other disease. So this means that this disease is continuing evolving. So how we can really block the progression of this disease with standard chemotherapies was not addressing the fundamental problem that this continued genetic alteration and instability, in particular trying to detect this instability and these mutations that may appear over time. And of course, there are different types of triple negative. We were probably naive to believe that there was only one type of disease. First of all, because clinically they behave different. Some of these patients actually respond very well to everything and survive for a long time. Some others not, and somewhat in the middle, we have the majority of the population. So again, when you look at the expression profile, you see that there are genes that classify these different subsets or subtypes of the subtype. So triple negative defined by the lack of expression of ERPRR2. And when you look at the expression of these genes, you start to see not only we knew that there was a basal-like, but now there is a basal-like 1 and 2. And one of them is driven by the p53, as we talked about. There is an immune signaling, and this is obviously hope for the future of immunotherapy applied to some subset of the triple negative, an immunomodulatory effect. There is a mesenchymal subtype in stem. These are the stem cells that we just touched on. These are the cells that are resistant to chemotherapy because have a different mechanism of pump efflux of the chemotherapy agents, so that they really don't get enough chemotherapy agents. And then the best group is probably the luminal IR, where androgen receptor is expressed. And of course, we have agents for this group because these are the ones that are used for prostate cancer in general. So there are some groups which we know exactly what to do, and we have to develop the studies, where others that we have to develop better therapy because the cells are different compared to the overall epithelial cells that we are used for breast cancer. There is an area for immunomodulation, and there are others where chemotherapy can work better and more effectively, and we have to use chemotherapies in a more judicious way. So this is from the same paper when it showed that, in fact, the different subtypes can respond when you use cell lines and in vitro and in vivo model to the different agents, so that the basal-like respond to the cisplatin, and it can also respond to some of the Parp inhibitor. This is the androgen receptor for the androgen receptor positive. And there are others that actually don't need that, and this is more of a molecule that attack different proteins expression that we don't have time to talk about. So the implication of this for triple-negative breast cancer patients that we can subdivide in different categories, and of course all different pathways activated give an opportunity for develop better drugs that have a better chance for improvement. And I think the overall message is there is not one drug for everyone. So if we expect to give the standard chemotherapy agent to every triple-negative breast cancer patient and see the same benefit, that's not possible because only a fraction of these patients are chemosensitive based on the fact that they have some DNA damage genes activated. Some others will not respond. So we have to be careful in the way we direct therapy for triple-negative patients. So there are a number of studies also in the adjuvant, neoadjuvant that continue to explore different questions. I think the neoadjuvant, as I mentioned to you, is really an area where you can test an hypothesis. And some study was shown, again, the bevacizumab in the neoadjuvant setting combined to chemotherapy appear to be increase the pathological complete response. So up front, we want to do everything possible to increase the pathological response. And the other agents, the other class of agents is the Parp inhibitors. And this is something that we also contributed at Jefferson. So the CLGB study is one of the studies. There was also a study run in Europe from the German group, essentially that there is an increase in the pathologic RCR, particularly in the breast, and not in the overall in the breast axilla. Of course, this comes with a price of toxicity. There are some toxicities related to bleeding, hypertension, and so forth. And we know that bevacizumab, for that reason, is really not overall a safe drug, but has been certainly effective for a number of women. The drug is not approved, so it's not available. I think the question remains if angiogenesis or targeting angiogenesis for women with triple-negative breast cancer still is an option. More targeted therapy, as I mentioned, looking at the fact that DNA damage is one of the mechanisms of repair that is missing, particularly in women that are BRCA1 or 2 mutated. I think the PCR or the combination appears to be usually better than when you use a single agent, particularly very high, and there's been a presentation at ASCO in women that have BRCA1 mutated, how they have extensive DNA instability. So that could be a way to select women to get very high pathologic RCR, up to 50% when you use this combination. And that will include, of course, the patient that have, in fact, a mutation. germline mutation. So this, obviously, there is a lot of attention on carboplatin being probably the drug that we want to use in triple-negative breast cancer. Right now, there is no comparison study. I think it will ever be with anthracycline because this is not the kind of study that we need. We know what is the pathological CR with anthracycline. We just need to improve on that. And just to say that we have a phase 2 neoadjuvant study at TJU, but we don't give away the anthracycline. The anthracycline is given after the induction phase with platinum, carboplatin and taxane and veliparib, and this is a randomized study. There is also a phase 3 looking at the adjuvant phase. As you see, nobody's giving the anthracycline away. It's just, in addition, trying to increase the effect on these unstable cells with the carboplatin of paclitaxel veliparib combinations. So this is one of the few Parp inhibitors still in development. This area suffer a lot from the previous lack of efficacy in metastatic disease. Once again, probably because there was an unselected population. And with regard to the iSpy, this is a platform for testing different agents. And as you know, this different agents target not only for the HER2 positive, also for the triple negative. And recently there has been some indication that combined effect of EGFR to targeted therapy can be effectively measured. And then there is evaluation of pathological CR. What we do in metastatic disease is different because we try to obtain a biopsy, as I mentioned, every time that we can, not only to confirm the standard markers. I think it should be more and more important to make assessment of which are the mutations that affect this particular recurrent disease, because this can give an opportunity for treatment that we never thought possible. So this is actually a paper that we published, was a case report, was a triple-negative inflammatory breast cancer patient that had a HER2 mutation, actually 2 and PI3 kinase. So you can imagine when you have a triple-negative patient and you start to see an HER2 mutation, immediately you have a number of possible therapies they can offer this patient. So she was treated with a combination of first lapatinib Xeloda. Of course, she has difficulty swallowing and she could probably not get full benefit. Then we changed the treatment and we include the Herceptin, and she had a response after 6 lines of standard therapy, never responded. You see the PET-CT, I think is self-explanatory. The disease that was in the chest wall and the lymph node of the face. She had a significant symptomatic improvement and radiological improvement for more than 6 months. So this is the proof that this mutation was a driving mutation. The HER2 targeted therapy was a problem. We will never find out if it was for the standard testing. When you do more advanced genomic testing, you can find targeted therapy that can be beneficial. But of course, this is something that we need to continue to do as much as possible, especially for patients that have resistant disease. And as I said, the residual disease is probably the source of information for the metastatic disease. Some studies have shown, in fact, a very preliminary study, that the mutation that you find in the residual disease after neoadjuvant therapy, the same mutation that you find in the recurrent disease when you get a biopsy. So if we have this time, and we know exactly what is driving the mutation, what is driving the resistant disease before it appears, would you do anything different? What can we do? I think this is a question. There are standard therapies that will be developed, and of course, some of these mutations are easy to target because the drugs are there, some others are not. But to design a study that has the power to prove that this genomic information is actually able to change the outcome of these women is really challenging. So as a community, we need to come together. We need your effort and your support for that. And there are other targeted therapies being developed. As I mentioned to you, the immunotherapy is very promising, not only for a number of different solid tumors, but could be also for breast cancer, triple-negative breast cancer. The first data on the combination with taxane seems to be extremely promising. So I would think that this would be the next big trial for triple-negative breast cancer metastatic. Androgen receptor based on the luminal type AR positive that we have seen on the triple negative. Obviously, this is another area of research. The Parp inhibitors, if you give to the right population, mutation carriers and triple negative, they have extensive DNA abnormality, and this is obviously in combination with chemotherapy. And there are a number that are investigated. There is still an mTOR activation, and when an affinity has not been approved for the ER-positive disease, for ER-negative disease, I think there is an area where some of these PI3 kinase mutated tumor may take advantage. And of course, how to modulate the inflammatory response, the immune response with other cells that are important, particularly in the neoadjuvant setting. So what about the blood? As you know, the blood is a source of information, and I'm sure that at one point we will translate everything that we know from the tissue to the blood. The other thing is the blood can be readily available every time we want. So we can look at the cells, we can look at the DNA of the tumor. And what we are doing with the DNA is to identify mutations during the treatment that can tell us about this instability. So as a group, we investigate the cells for a long time. Now it's been 10 years since the first publication. When you are able to identify cells in the peripheral blood, these cells are informative of your outcome in metastatic setting and also in primary. Just to say that patients have CTC more than 5 at the presentation, they progress much quicker and they do not respond to treatment. And it's not a surprise that most of these patients are in fact triple negative. And their survival is certainly shorter. So triple negative patients that have CTC are the worst, but this is only 40%. So the other group, for whatever reason, is a triple negative, belongs to the good group. And the question is what to do with that. So we know that for the ER-positive get endocrine therapy, having CTC is almost an indication of resistance. And investigating that, we start to find out that these cells are in fact estrogen negative. So why you give an endocrine therapy to someone that is essentially triple negative? That's what I'm saying. So there's a group of ER-positive that in fact behave like a triple negative disease, even in the one that we consider ER-positive on the tissue, because this is a very dynamic process. And with regard to the chemotherapy group, the one question it was asking in this retrospective study, not only the fact that you have CTC, you do worse, but if you do have a combination of chemotherapy versus single agent, do you do better? Well, there was a trend in showing that patients that have CTC, they probably respond quickly and actually do a little bit better when they have combination chemotherapy. So start to give some indication that your selection should be somewhat directed and not based on your experience. And this patient probably will need a little bit more aggressive treatment, not necessarily only chemotherapy though. But the other thing is, what if there is one metastatic site only? Well, we know that the CTC will tell us one thing, that this patient have more than 5 CTC, one metastatic only, cannot be cured because they develop visceral metastasis and they do worse. So we have to be extremely careful in developing therapies for the group of patients that have a more aggressive disease, and we have a way to identify. But there are some good news though. As I mentioned to you, in the tissue we can identify cells that are HER2 positive with a mutation. Here we can identify HER2 positive cell with expression. So when we run our test, there is a fraction of patients that have between 20 to 50% of the cells HER2 positive. What do we do with this information? I think what we should do is try to target these HER2 positive cells and try to essentially treat these patients in a more effective way. So that's what we did. This is something that came up on the New York Times a while ago. We were trying to understand how this woman that was actually at the beginning ER-positive and became eventually triple negative, was going to be treated because we didn't have any other treatment available. And we found out, first of all, she had some mutations, but we had already treated that mutation, but also that the CTC, 50% or more of the cells were HER2 positive. She was treated with HER2 targeted therapy, the cells drop, she's doing well. So we need to consider that there are new tools for understanding the evolving biology of triple negative disease and breast cancer in general. So how can you help? Well, we need to talk about clinical trials every time we can. Different phases of clinical trial, and understanding the phases is very important because, first of all, they build the standard of care. And really, there is no much placebo any longer for most of this clinical trial. You're always, if you are in the phase 2 or phase 3, if it is a randomized study, you receive at least the standard of care. So we have, for example, coming up one major triple negative breast cancer phase 2 randomized study. This is going to be in multiple institutions, but this is a drug that is going to target cancer stem cells together with chemotherapy. So if you get one of the standard arm, you continue to get chemotherapy as you will if you don't participate. But 50% of these women will receive, in fact, also a drug that could be the future of triple negative breast cancer patients. So we cannot improve our future, improve standard of care without doing clinical trials. So as you know, the phase 1 study look at safety, dose findings, and these are new drugs or combination of drugs. Sometimes when you combine 2 old drugs together, and we don't know the toxicity, this is a phase 1, but most of the time what the triple negative community is looking for is new drugs. And there are some other new drugs being developed specifically for triple negative disease, sometimes combined with chemotherapy. So this is not a totally new study. I mean, it's a study where some of the toxicity is already known. Of course, the phase 2, you look at the efficacy, you want to improve the response rate, even though response is not a very accurate, but the progression is more accurate. So we try to prolong the progression of the disease. I think that's very important. Of course, the phase 3, everybody would like to participate in phase 3, but there are not many out there. And we have to get to that point. So why participate in clinical trial? Well, for triple negative patients, there is not really many standard options, as I show you. So you may access these promising new drugs only by participating in clinical trial. Of course, moving the field is very important, and up to the future of these patients. Obviously, there is no guarantee that any study will show an improvement, even though the more we select, the more we target, the more we restrict the criteria for participation in the phase 1, in particular the phase 2, and the better is the possibility of response. In the past, phase 1 trials had a response probably in the range of 2 to 5%. Now, with a new molecular targeted therapy and a very careful selection, this goes up even to 20%, similar to phase 2. So there is no guarantee, but it's probably a better chance than unselected treatment. And of course, when you have randomized studies, you never know if you're going to be assigned to, but you have 50% chance to get to one. And of course, you have to try to look for this. You know, many of you are really very active in going to the website and trying to figure out where the clinical trial. Of course, it's time-consuming. There are scheduled visits, biopsy. I think overall it's worth it, and that's the way we try to develop trials that are more optimal for you. So don't take your treating oncologist's word for if they don't offer to you anything. If you're just under therapies, particularly for triple negative, always look for a second opinion. You want to know what is out there, what is available, what can be done, instead of just standard treatment. You can always look yourself. You can have information for the triple negative breast cancer foundation. Certainly try to be proactive in your care. This is an important time, and the recurrence time at the beginning is the most important time. And regarding advocacy and mentorship, these are the information, the local groups, the triple negative foundation. I think you're here and you already know that. Just to spread the word, it's very important that patients talk about this disease, talk about the opportunity, talk about the research, advocate for the research. Once you understand the disease, you understand why the research should be done, because it's life-saving. It's going to save more life in the future. So just to summarize, you know, this is not one disease. Triple negative disease is very complex. There are many different types, and different types of therapy will be developed. Clearly, what this disease is very genetically unstable. Continued changes, we can capture these changes in the blood. We can identify these mutations. Some of them will be easy to target, some others not, but certainly we'll have the opportunity to include in clinical trial. And this technology, this advanced diagnostic, will tell us everything about the disease. There should be no surprise any longer. We have the technology to interrogate the disease. In the future, you know, there is a lot going on in understanding the mechanism of resistance and do personalized therapy. As I mentioned, there is no way that we can simply just prescribe the next treatment without having understood the disease. Where are we in terms of your outcome, in terms of your biology, in terms of the mutation? All of that time, we can develop a really careful thought plan. So talk to your oncologist about the multiple options to better understand first before jumping into the next therapy. And of course, there are new therapy and effective therapy that will be probably also with less side effects. And some of them will be extremely effective compared to chemotherapy. So there could be a future without chemotherapy for triple negative metastatic breast cancer. I don't know. I hope so. And of course, immunotherapy will be the first one to be tested, and we'll know pretty soon. And so thank you for your time, for your attention, and I was very happy to be here today.
Yeah, if you would stay up here, or if you'd like to sit down and take questions. So we said we will take your questions by text. Here is the number. So please text your questions. Is Kendra in the room? Kendra? Okay. Arlene is going to pose the first question, and if those of you who do not text want to write on a piece of paper, Arlene will pick them up, and maybe Haley will help out if there are those. But Arlene will pose the first question, and then I'll start to read your questions and pose them to the doctor.
If anyone has one written down, I can start with one that's written down.
Well, I have one already, so I'll start. Okay. I'd like to thank you, first of all, for a wonderful presentation. It was very detailed and very informative. So there's some confusion, I think, about how the hormone changes from negative to positive. Could you just comment on that and what that means for your treatment?
So we mentioned that some patients have bone metastases only, particularly for this group. They have the possibility to, for some reason, have estrogen-positive disease. Remember that the first biopsy is always sampling part of the tumor, not everything. So it's quite possible that there is very heterogeneous disease. After the whole treatment, some of this disease will eventually become metastatic. Of course, if chemo kills the most active disease, the one that is less aggressive, certainly don't grow that fast, are typically the one that are estrogen positive. So in some cases, particularly for women that we had bone marrow metastasis, we're starting to continue to do chemotherapy because the assumption was a triple negative. When we did the bone marrow aspirate, because we were suspicious that these women were not developing brain metastasis or liver metastasis like is expected with triple negative disease, and we found out that these tumors are in fact ER positive. So it's a selection process, and thinking about the site of disease, the selection process, you always need to biopsy to confirm, because a bone marrow or bone metastasis that is ER positive, of course, can be treated more effectively with endocrine therapy than with chemotherapy.
Thank you. After having surgery and chemotherapy, how high is the risk of reoccurrence? Is it higher than with other types of breast cancer?
Yes. Depends, of course, on the size of the tumor, the lymphnodal status. If you had a neoadjuvant therapy, you had certainly evidence of high risk based on the study that I show you. If it was an adjuvant, we know from the previous study in the different subtypes that basal-like and triple negative has a higher risk of recurrence. Of course, we are not talking about the 1 centimeter tumor that has a chance of recurrence, but not that high. We're talking about larger tumors. Compared to others group, yes. I mean, the ER positive have endocrine therapy, now up to 10 years in some cases. The HER2 positive get HER2 targeted therapy with or without endocrine therapy. The triple negative and nothing. So if there is a fraction of cells that are resistant, they persist after adjuvant therapy, there is a high risk. So I think the high risk is because of the biology, but also because of the lack of therapy after the chemotherapy.
This one kind of goes along, if I could read out. What are the post-treatment diagnostic tests that should be used for triple negative?
That's a tricky question. There is no recommendation from the ASCO guidelines in terms of what to do when you have a high-risk situation. I personally use, tumor markers, and depends on the type of disease. I think we need to have risk adjusted for our inflammatory triple negative, where there is a very high risk of recurrence. We even perform PET-CT at 6 months and eventually a year, because we know that this is the type of disease that will recur in the lymph nodes, will be not symptomatic for a long time, and then you have it in multiple sites. So I think when there is no standard recommendation, should be adjusted based on all your risk. So if you have a very high risk, large tumor that never responds to chemotherapy, I think it would be very difficult for everyone just to say, let's watch and not doing anything, at least tumor marker. There is this area that's been presented at ASCO where we can detect the DNA of the tumor in the blood, and these women have trace of the tumor in the DNA in the blood. They have a high risk of recurrence. I think this test will become more and more used. Not being a recommendation in any guidelines, insurance is a problem, as you can imagine. So I think that has to be adjusted to every specific case. But I feel uncomfortable not to check for anything when there is a high-risk condition.
There's a question, how can you find out what cell type you have? What are the questions you could ask your doctor to give people some questions they can take back to their doctor so they can find out what they're, where they fall?
For a newly diagnosed tumor, usually there are tests based on the RNA expression profiling. Mama print, blueprint, for example, is one of the tests that will tell you which, if you're a basal-like triple negative, or if you're a luminal B with some expression of estrogen receptor. In the metastatic setting, I think there is more and more pressure in trying to do this genomic test to identify mutations because the fact that you are ER, PR, HER2 negative is not enough to help you planning for the next treatment, and these mutations really need to be discovered. So there are standard commercial tests. The one that I showed was Foundation One. It's been around for now 2 years, and there are many, many publications that show that could be very useful for selected cases.
We have some questions about the BRCA testing and genetic testing. Since there has been a new gene identified, if someone had a test years ago, should they ask their doctor to retest them?
Well, I think this will depend on the risk. And if there's a strong family history, nothing has been identified. There are now other genes that can be tested. There are probably 20, 25 genes associated with increased risk. If it was several years ago, I think it's possible that this can be useful.
Okay, thank you. Arlene?
Is this DCIS?
Yes.
Okay. Why don't they test for HER2 status in DCIS?
They actually do test for HER2 status many places in DCIS. It's just that we don't use Herceptin for DCIS. There have been studies that are looking at the effect of Herceptin on DCIS. It's just that it's not cost effective because it's a condition that can be cured with treatment, with surgical treatment, radiation therapy. Yeah.
Okay, so perhaps she needs to ask a question of her doctor about testing.
Well, at least we do, and usually academic institutions.
One person asked she's triple negative with HER2, and what determines if you are given Herceptin or not?
So if you have HER2 mutation, I think you should receive Herceptin or other HER2 targeted therapy. If you are a triple negative, you cannot be a triple negative with HER2. But if you have HER2 or any other marker that indicate there will be a selection for targeted therapy, I think you should receive that targeted therapy. And sometimes we have to argue with insurance because that was found to be triple negative, and now we have an HER2 mutation. This is becoming easier and easier because they understand that these genomic tests are more used in clinical practice now.
Does having triple negative breast cancer put you at a higher risk for other types of cancers, liver, colon?
Only if you have a genetic predisposition to these other cancers. So otherwise, no.
Many of the questions, really want to know what the targeted therapies are, and you did talk about some pipeline therapies for triple negative.
Yeah, I think there are others being developed now. I don't want much going into the specific, but there are some alterations, some mutations that are being targeted. c-Met amplification is one drug. As I mentioned, the stem cells. The stem cells can be characterized also from the molecular point of view, and one of these mutation is Notch. So Notch targeted therapy being developed, particularly in triple negative. So there are a number of these targeted therapies. I mean, you can certainly look at the NCI website and find some of them. But I think the beginning of it is we need to test the tissue and see if there is a target for it. Very few will be just developed, and I think it doesn't make sense certainly to be developed without any understanding of what the underlying biology is, except for the stem cell targeted therapy, because triple negative is a stem cell rich disease, and so eliminating this fraction of cells that are the one that migrate and seeds and create other new metastases is the goal of every new therapy. So we don't want to only kill the cells overall, but we want to also eliminate the one that are able to generate other metastases, stop the process.
I think these sort of go along
Okay.
with what
One is asking about what is the future of using Avastin for TNBC.
Well, I don't think there is future because this has been pretty much a closed chapter. In Europe, it's still used. I think the first line taxane bevacizumab is still used in Europe. I don't know if they have any long-term data in terms of survival. The healthcare system pays for it. That's kind of unusual because it's most of the time it's a national healthcare system and the drug is expensive. But you know, as you see, there are maybe different standards between Europe and the US. I think we are more pragmatic and we wanted to see an advantage in survival. Overall, I think there have been patient benefit from Avastin. The development did not select for these patients, was not looking for it, just wanted to give the drug to everyone. And this is a mistake that we keep doing in drug development. So some of these trials for everyone just simply divide between two as a randomization will not show the benefit, not because the drug is not effective, because the patients that are assigned to this treatment are not the right one. So there are many treatments out there. We just need to find the right patient to be matched with that treatment.
There are a lot of questions about testing, and if you didn't receive your subtype, what can you do to get that information from your doctor?
Well, I think if you are a triple negative, the specimen, either a surgery or biopsy, is still available to be tested for these different subtypes. If you have a recurrence, I think you want to get a biopsy as much as possible. You want to make sure that this biopsy is analyzed for a number of different mutation protein expression. So because that's the source of information for the treatment. And sometimes, when there is a difficult to get a biopsy, now we can use the blood for getting that type of information. So I think you need to ask your doctor because he needs to be knowledgeable about it. And if he's not, as I told you, you need to look for a second opinion always.
And can the doctor, if you go for a second opinion, that doctor can request the test, and then you can get it through that doctor?
Yeah.
Great. Do you recommend genetic testing, again, another testing question, for all TNBC patients?
Well, I think we're going probably in a situation where there will be more genetic testing offered to a larger population of patients, and many of these will be triple negative, especially if they're young, especially if there are some acting groups, and especially if they have even a hint of familiarity for some cancers, obviously breast cancer, ovarian being the first. Because this, at the end, may contribute to save resources and certainly to prevent additional problems. Hopefully, it will not be a push to do more prophylactic mastectomy and ovariectomy, but this is the right of women to know, and these tests have become available for a larger fraction of patients.
Thank you. How effective and reliable are tumor markers when we have false positives or false negative readings?
Well, yes, tumor markers are the bad and the good of the monitoring of breast cancer. Interesting enough, the ASCO guidelines always argue against new introduction of new markers, but never made a point regarding tumor markers. So the tumor markers are the only thing that we have, even though they are not perfect. In some patients are effective tumor markers, meaning that they go up well before the disease is shown. Few months, and many others, particularly in triple negative, doesn't seem to be such an effective marker. So I think we have a limitation, but it's the best that we have. I show you the CTC being one of them. The DNA is catching up very quickly. So there is another way to look for this evidence of disease, even before it becomes detectable.
This is a question about lumpectomy versus mastectomy, post-surgical percentage for recurrence. People are very concerned about recurrence and how to make those kind of decisions.
I think the decision has to be made when you are in the context of a multidisciplinary team. This usually review very carefully every single imaging for these women. If there is diffuse calcification and the planning for lumpectomy is borderline, you cannot reassure they're going to remove all the suspicious calcification, or there is an area outside the area that is going to be resected. I think it's clearly that maybe a mastectomy will be the option. Sometimes surgeons jump into the lumpectomy because women want it without explaining what the risk is. course, in genetic conditions, there is a chance to develop another primary in the same breast. You need to be aware of that. And what you do for monitoring, MRIs, of course, is used more and more compared to mammograms. In general, if everything is done very carefully, there is no difference in recurrence between lumpectomy and mastectomy. Certainly, there is no impact on survival. But if you compromise because of margins, DCIS, and genetic conditions, then you have another tumor. And these tumors may be more aggressive or different. We have seen that happen sometimes.
There's been a number of studies coming out looking at prophylactic mastectomies, and maybe they're not as effective as once thought. How does a woman go about making that decision? What are some of the key questions she can ask her doctor?
Yeah, I think, we have to distinguish between someone that's been found positive for a test and has not developed breast cancer yet, and I think Angelina Jolie was an example where you could prevent breast cancer to come in the first place. And the other one is what the effect of prophylactic in someone who already had breast cancer, where the prognosis can be affected by the cancer that they had. So when I have patients with inflammatory, especially triple negative, they are BRCA1 and 2, and they're thinking about prophylactic mastectomy, but we know their disease is deadly, it's very aggressive. So I don't know if it's enough push to actually perform a prophylactic mastectomy. It may have no impact on the overall survival of these women. So I think it's always a careful assessment of benefit. Otherwise, and we have seen occasionally women that had mastectomy and reconstructive surgery, and some tissue was left behind, even though this is not something that you commonly see. So the skin sparing mastectomy, there is always some tissue behind. If it's very high risk, you can develop. It doesn't completely eliminate the risk of breast cancer, but it's around 1 to 2%, but something to be aware of.
Thank you.
Should scheduled doctor's appointments after treatment include testing for tumor markers, such as at each 3-month appointment?
Well, as I said, it depends on the risk. Doing testing for everyone is not cost effective. It's not going to be very helpful. It can increase anxiety. But if you had a locally advanced tumors and there was no good response, and we are concerned about possible recurrence, I think it makes sense. It's certainly something that we do more commonly than not, and it's better than nothing. I do it.
Well, let's see. This is another genetic. This is a good question. The questioner understands that triple-negative breast cancer is found mainly in Jewish, Hispanic, and African American and young women. But what about people of German heritage or other kind of heritage? Should they get testing also? And some are concerned.
Yeah.
I'm sorry to interrupt. And some are concerned about children and
yes,
sisters.
I mean, if they have a triple negative and there are some other cases in the family, if it's the standard criteria for having also insurance to pay for the testing, I think that should be, it's becoming more possible to test when there are these conditions. Now, German's origin doesn't mean that there's not being, as we say, 10% or more of these women may have, in sporadic cases, indication for testing and found to be positive. Don't forget, the association with pancreatic cancer or prostate cancer, to look at the family history. Definitely refer for a genetic counseling to build the family tree and see what other diseases may be there.
There was a questioner was confused about the difference between hereditary and familial cancer. On the slide.
Hereditary is when you have generally identified the genes that are responsible for the development of the disease. Familial, when you have familiarity, there are a number of individuals with the same disease or other cancers, but the testing did not reveal any mutation. So you have a predisposition, high risk, but we have not pinpointed. And maybe doing this standing testing, eventually we're going to find out which other genes are involved in genetic risk. And as I said, there's more hereditary and less familiar unknown that would come up.
Thank you.
This participant wants to know what type of exercises she can do to build up her energy since her surgery, and what would you recommend for pain?
Well, that's Well, I think we'll talk about the side effect of the chemotherapy later, but in general, you want to make sure that you don't get lymphedema, you prevent lymphedema, you have a possibility to increase the range of motion. Your surgeon should have recommended that type of exercise. One of the risk factors that I didn't mention was also obesity and being overweight. Certainly, in general, for breast cancer, has been a recognized factor. And talking about the risk factors, alcohol consumption, smoking, obesity, and so forth. So the more exercise to maintain or to lose weight, changing diet, mobility of the arm, and some of the side effects of the chemotherapy will eventually go away. Pain can be tricky because some of the pain is related to the surgical site, and there could be reason for that in terms of scarring reaction or post-radiation. Certainly treat with pain medications. This can be more a neuropathic pain, so different type of pain medication. I think you need to talk to your physician about that. If this is a shoulder pain, then you may have a frozen shoulder. That's obviously something that you want to address with physical therapy as soon as possible.
So there are many treatments for pain, but you should talk to your doctor about the specific one that's right.
Yeah.
I'll summarize that. Someone is wondering about heart issues with ACT and what
Well,
should...
the complications, the cardiovascular complications from chemotherapy are not as common as we used to be in the past. We were very careful in selecting. Actually, most patients with HER2 targeted therapy are the one prone to develop complication with HER2 targeted therapy, anthracycline, yes or not, etc. So that is becoming a focus of research more and more with cardiologists in academic institutions. I think for anthracyclines, we don't ever reach the high dose that we used to do in the past. And you can use epirubicin instead of doxorubicin. If you look at the dose of the dose dense, it's never very high overall total dose. So there is no major cardiovascular risk. Of course, if you do have risk of upfront cardiovascular with hypertension and so forth, there have been studies looking at combination that would not include the anthracycline, equally effective. It's a matter of discussing with your physician what is the compromise for that.
Thank you. There are many questions about recurrence and fear of recurrence. What role does diet play in recurrence? I'll start there.
Yeah, I mean, a few years ago, we did a retrospective study using the database at MD Anderson that showed that women who were overweight and obese had a higher chance of a recurrence for the one at risk, so locally advanced and inflammatory. And then others had a higher chance to develop visceral metastasis. So clearly there is a correlation, and this is not because it doesn't receive enough chemotherapy up front based on adjustment on body surface, area, weight, and so because some other biological factors. The obesity is a pro-inflammatory condition. It may have also an immunosuppressive effect. A number of research done in the lab, and of course in these patients have identified some of these factors. So clearly changing the diet, try to lose weight, is always recommended because it can be a preventive strategy.
Okay. Should people get PET scans after they are done their treatment?
In general, no. I mentioned that some of the diseases that I see in the clinic are inflammatory with high risk, and they develop mostly soft tissue and lymph node recurrence, and this cannot be detected by physical exam or even standard CAT scan. So we try to use PET-CT as part of the monitor and follow-up for inflammatory, particularly for the triple-negative patients. And sometimes we detect the disease very early on before it becomes symptomatic. I cannot say that this has had an impact, but a recent publication that we had showing that this aggressive monitoring in this patient with inflammatory, when we opened the clinic at MD Anderson, these patients overall are doing much better than historical. Of course, detecting a disease before it becomes symptomatic may make a difference in terms of treatment and outcome.
Okay.
Do you mind repeating, in the presentation you talked about CTC. Can you tell us exactly what that is?
So there is a blood test using one tube of blood to measure the number of cancer cells in this tube. And this has been proved over and over again that if you have more than 5 CTCs for patients with already developed metastasis, you have a much more aggressive disease that typically doesn't respond to standard therapies. And if you don't, then the disease is usually responsive to many treatments. There'll be a number of studies trying to find out exactly what it means. One of the latest published on JCO and presented in San Antonio last year showed that for the patient that have CTCs, and they are persistent CTCs more than 5 after 3 weeks, changing to another chemotherapy will not have an impact. Why for the one that have less than 5, they do very well. So I think what it says is that there are 2 different types of metastatic disease, irrespective of what disease subtype you are. You need to ask your doctor to test because it's very important. It's a better marker to monitor response than tumor markers in metastatic setting. If the disease has less than 5 and persists less than 5, you can almost be sure that it's responding to therapy or it's not progressing. If it's not going down, doesn't matter what the imaging says, there is a high chance that this will progress very quickly. It will progress by develop other sites. These cells are essentially floating around and going to other sites. So I think it's an important discovery because we have a way to monitor and to understand the disease at a different level. And now the next step that everybody's working is trying to get the mutations in these cells, so this is the biological information, so that we can try to eliminate the CTC that are the seed for metastasis. So there is hope in that respect that we can actually do better. I don't know if it's clarify anything, but.
These questions are coming fast and furious, and it's a wonderful questions. Thank you. Someone did ask if the PowerPoint would be available, and yes, it will be. And we are also, as we mentioned, we are live web streaming, and we welcome everyone from the web stream. Some of these questions are from our web audience, but you will be able to go on to lbbc.org and look at the web stream again. So if you want to sort of check on what you heard and formulate some questions for your own healthcare providers, you can do that. Someone asked about, again, going back to the genetic testing, with children, is there an age when you should have your children tested?
No, I don't think there is any specific age. Just you need to think about the disease that you have a risk of. If you are test positive and you have a risk of breast cancer, you don't want to go to your daughter that is teenagers and try to start testing, and because we don't have breast cancer in teenagers' age. So I would think that instead of traumatize this young girl, we want to wait at least in the early 20s, and then starting maybe a monitoring strategy that will include MRIs, because a dense breast and mammogram will be not useful. And give it the possibility to elaborate what their choice would be in terms of prophylactic interventions. I think we have to be careful in the way we include this information. Too much information at the wrong time cannot help.
Very good. Someone is concerned she's had reconstruction after a double mastectomy, and in her follow-up visits, how is she monitored?
Well, there is no breast imaging because there's a reconstructed breast. The breast tissue is probably be completely removed. Depends on the original tumor. Sometimes if there was a large tumor to start with, we may want to do an ultrasound for the lymph node that we don't see, just to make sure that inside nothing is happening. But in general, it's more of a physical exam follow-up.
Very good. We have time for one last question. And it's so hard to pick, but this is going back to diet. Is there any, should we be eating organic food, or is there any research
Always.
on organic versus regular?
Well, organic food is obviously the solution. There are a number of estrogens be used in the industry, particularly for meat. We hear about poultry being raised with estrogen supplements and so forth. I think you want to stay away from anything that includes any chemicals or any hormone, and certainly organic should provide at least some guarantee that that is done, and how much will impact our health remain to be seen. One day we'll be able to monitor in the blood also your health in a way and see how these different factors, exposure to pollution and diet, may actually affect our possibility to develop cancer. Environmental factors are very important. Genetics is something that we know play a role in 10% or maybe a little bit more than that, but the majority of the tumors are not related to genetics. So.
Well, thank you so much for answering so many questions. Thank you all for your questions. I bet it is to you. These were fabulous questions. Our closing plenary, we're going to have a break now, and then we'll come back for the second workshop with TNBC. But at the end of the day, we will be talking a lot about diet and exercise and some of those issues that you're all concerned with. So thank you so much, and we see you back.